The FLAURA trial, I think it's nice to always have a trial that you could know the name, and F stands for first line, and this is the first line FLAURA trial for osimertinib given in the first line setting to tumors with EGFR mutations 19 and 21. So the first thing to say is they did not include the uncommon mutations, and now most of us that are doing next gene sequencing are picking up those 10% uncommon mutations. The second thing to say is that patients were randomized to osimertinib or to erlotinib and to gefitinib. And they were not stratified for their erlotinib and gefitinib. That was pointed out by Tony Mock in the discussion. And that's also important, as he pointed out, erlotinib might have a better CNS penetration. But probably more importantly that the trials did not involve the second generation drugs, both afatinib and dacomitinib. And we know that those have been shown to be more efficacious, although more toxicity, but more efficacious than erlotinib, gefitinib. And so coming into this meeting, the FLAURA trial, I was very excited. We know from the early AURA trials where, patients that were treatment naive, they were hitting PFSs around 19 months of 60 patients. And personally, I was hoping for greater than 20, even a 23, 24, 25-month improvement in progression-free survival. And so I'll have to say that when we saw 18, I think that's a positive trial, but it wasn't as positive as I wanted. It wasn't the slam dunk of the ELK trial last year with alectinib of 25 months. Because if it had been, then we probably wouldn't be having these discussions right now. But at 18 months, and everyone is starting to think about sequencing. The dacomitinib trial from the Archer 1050 came in at 15 months or 14.9. The AURA trial, second line, came in at 10.9, so you wonder if that sequencing would be better than giving everyone osimertinib first line. That's in everybody's head, and including the discussant's Tony Mock. Now, what you can say about osimertinib, that's an extremely easy drug to give. It's way easier than afatinib or dacomitinib in terms of diarrhea, rash, paronychia, stomatitis. But, is that sequencing beneficial for that patient who we've learned to really manage these side effects in these patients? Now, Dr. Mock made a very important point that osimertinib, unlike the other TKIs, both first and second generation, has excellent CNS penetration. In looking at those numbers from both AURA 3 and the FLAURA trial, I say that the CNS penetration is there. So I think I would agree with him in patients who present with an EGFR mutation with CNS metastases, osimertinib should be the first drug of choice. But for the others, I think we do have to wait for overall survival. I think there's time for the oncology community to actually sit down and think. And so not a slam dunk. I think that it opens up to discussion, which is good. I think all discussion is good, and choices are good. So not a slam dunk, but again, I think the CNS metastases will be their niche for now. Again, I would think that if I see a patient tomorrow and they have a EGFR mutation, a 19 or 21, they have a CNS metastases, I think osimertinib is the drug of choice for them. Well, we are all, as Canadian oncologists and across the world, we all are struggling with T790 testing. In my own center, we just put a proposal in for not only plasma but tissue, but not one of each, but two of each, because we want to find those patients for T790 positive. The FLAURA trial, you don't need to do any testing. Everyone's getting osimertinib up front. But again, you have to come back to the progression-free survival for the whole group of 18 months. And is that really in the best interest of that young patient where you might be able to sequence those drugs? Yes, I think OS is going to be really the key. There still are, as Dr. Mock in the discussion pointed out, there are 62 patients still in the standard care arm, either on erlotinib or gefitinib. And so, we really want to see that overall survival because it may change.